I just want to take 2 minutes to thank everybody. I know we've been extremely busy, and there's always I guess a trickle-down effect or an unseen effect that for every transplant we do, there's hundreds of hours behind that, either in evaluation in the lab with the other, people who are being readmitted, with the floor, with the OR, and I know we are busier than everybody anticipated, and I just want to thank everybody for their hard work, especially around the holiday time. We did 4 well, not we, I mean, I didn't actually do any transplants, but these guys did 4 transplants since the 2nd, which is just a tremendous effort over a holiday time, so thank you very much. And if I could read, I could find my presentation. Okay, here you go. My goal is to keep this pretty brief. A lot of it was covered already. I'm more than happy to answer any questions, but basically for those of you who don't know, I realize that transplant is very siloed. Those of us who work in the pre-transplant side live and die by UNOS. Everybody kind of lives and dies by CMS, but UNOS and UNET and allocation and all of these policies, this is what we eat, breathe, and sleep. So for those of you who work on the floor in the OR, this might not be as familiar to you. So I wanted to give a little bit of background. What is UNOS? Why do we have policies and about organ allocation? And again, this is extremely brief. I will tell you, you can go to optn.hrsa.gov, and there's a slide in here that shows it, and it has, or unos.org, 2 very huge, very good resources for anybody who's interested in UNOS policy development or UNOS or transplant. Very easy to navigate and a very useful website for patients and for staff. So UNOS basically was, for those of you who've been involved in transplant for a while, NOTA came around in 1984, which did a bunch of things. And one of the main things that it did was establish this Organ and Procurement and Transplant Network, or OPTN. 99% of the time, OPTN and UNOS can be used interchangeably. UNOS holds the contract. The OPTN is the government office that controls it under HRSA. So technically, somebody else can bid for it, and it actually is a contract year. They are up for they're asking for RFPs. The scope of work and the specialty is so tremendous that I don't think there's ever been a competitor. I think this year there are 2 or 3 that are interested, but almost nobody has the infrastructure and the ability to do what UNOS does. So, and it also did create the SRTR. I believe somebody, I don't know if it's Dr. Tedler or Dr. Grusner, referred to the 1-year and 3-year outcomes, and every 6 months another cohort comes out. I believe the next ones are due out July 18th, today. Yeah. Soon, next week. I think it's Monday. Very soon. They either come out in June and December or July and January, and every 6 months there's a new cohort that comes out, and we are mandated to give that information to our patients. So what is UNOS? UNOS is a not-for-profit charitable membership organization that runs the OPTN. It is their responsibility to make the policies. Before I get into that, and who are the members? Transplant hospitals, organ procurement organizations, histocompatibility labs, public organizations, TRIO, others like, the TRIO's a recipient-related organization. There's medical and scientific organizations, and there are people who are individual members of UNOS, although I really don't know why you would do that. So what does UNOS do? Basically, for our standpoint, the most important thing is it maintains this national transplant waiting list. So when people ask, where am I on the list? UNOS maintains that. You've listed in Downstate, Columbia, Cedars-Sinai. It doesn't matter where you're listed with UNOS. It establishes equitable organ allocation policies, although a lot of people would dispute that fact, but it does the very best that it can. It's almost impossible to try and allocate a scarce resource to over 130,000 people in a way that people are happy. So somebody is always dissatisfied, but they certainly do the best they can with a large amount of input from the community. It monitors members for policy compliance. Anybody who was here when we had our UNOS survey is well aware of that. They do a lot of data collecting, and they now have a lot of center-specific data available to us on our secure website that makes it a little easier for help do some of our QI. They do communicate with the public, and they do some education, but that's not their main focus. So as for what the primary purpose of this talk is, as far as organ allocation, the whole goal of organ allocation, regardless of what organ you're allocating, is to try and balance justice and utility, decrease wastage, and they look at it with waiting time, medical urgency, and net benefit being the driving forces. Organs are allocated basically in 2 different groups, or 2 different methodologies. Kidneys are based on net benefit. You have your kidney allocation score. You're trying to increase your longevity. The better kidneys go to the better patients with the longer life expectancy of the kidney. Liver and hearts go by medical urgency. The sicker you are, the higher you are. Your status 1A, you have a MELD score. So not every organ is allocated along the same principles. So this is the question we get from everybody. How do I get in the line? How do I move up in the line? And when is it my turn to be first? Well, to get in the line, you have to actually complete your transplant evaluation, go through everything that Maxine spoke about, and be accepted at the selection committee. People think that as soon as their dialysis center refers them to the transplant center, that they're on the list. It is amazing how many people have that misconception. How do you move up the line? That, again, depends on what organ you're waiting for, but if you're waiting for a kidney, it's just a matter of waiting, unfortunately. It's time. And when are you going to be first in the line? Well, that depends on the donor. This is not a, you can't go to the counter at Stop and Shop, when you're waiting for your deli counter and pull a ticket and you're like, oh, I'm number 100, they're at number 82. I have about 15 minutes. It doesn't work that way. It's donor driven. So depending on the donor, there's a new list generated each time. It's a dynamic process. You could be number 1 for a donor one day, you could be number 32 the next day. It depends on a couple of things. I know Dr. Noren hit on a few of these. It depends on their blood type. Depends on the tissue match or the HLA matching. It depends on their medical urgency, the waiting time, and sometimes the organ size. That's more for thoracic organs. You have massive size differences, obviously, between pediatric. You're not going to put a 13-centimeter kidney into a 5-kilogram baby, probably. But for the most part, thoracic organs don't go by size. Immune status and geographic distance. So for every organ, it's basically the same thing. Somewhere over here in some hospital, Jacobi, Kings County, Stony Brook, you have an organ donor. And someplace out there in the other 10 transplant centers in our donation service area, you have patients waiting. The organ procurement coordinator puts all the donor information into the computer. When we list our patients, Victor puts all of our information into the computer. And all of these data elements come together and produce a list. So if you have a donor in Kings County and a donor in Jacobi, and they're both O blood types, you could have 2 completely different lists based on the age of the donor, the KDPI of the donor, the antibodies, the antibodies present in the DSA present in the recipient, or the recipient's CPRA. So it depends. So somehow this potential list gets generated. We do what Dr. Noren showed with that cross-match report, and somebody someplace gets transplanted if the organ is transplantable. In general, allocation is local, regional, and national. And for those of you who are not familiar with UNOS, these are the UNOS regions. The big buzzword now is that they are arbitrary and capricious. That's what you'll see if you look at any of the comments that have to do with liver distribution. These were made back in the 80s. There really is no good reason for these. Geographically, they don't make a lot of sense. And within these regions are DSA, or donation service areas. I believe there's 57 of them. Sometimes they combine, or somebody unfortunately gets decertified. But there's 57 or 58. Our donation service area is downstate New York, like this little teeny piece over here. We're from Poughkeepsie south and then out through the 5 boroughs and out to the 2 counties in Long Island. That's our small little donation service area. So right now there's a whole big controversy in organ allocation about using donation service area because it's not really equitable. But for the moment, that's what we have. And some organs, thoracic organs, go by proximity circles. And at the moment, again, abdominal organs go by donation through local, then national, regional, then national. Again, there's some exceptions to that. Ironically, there's actually no medical eligibility required by UNOS for kidney transplant. You can list anybody for a kidney transplant. They won't get time, but you can put anybody on the list. There's no restrictions. If they're less than 18 years old, they start earning time as soon as they're registered on the waiting list, which is why we reach out to the pediatric nephrologists and encourage them, even if your patient only has stage 2 chronic kidney disease. If you know that they're moving towards the point that they're going to need a transplant, there is a huge benefit to listing somebody before they turn 18. I know very recently we rapidly listed somebody. He came to us, I think, 6 days before his 18th birthday. It makes a tremendous difference. If they're over 18, you can list anybody you want, but in order to start getting points for allocation, you have to have a GFR less than 20 if you're preemptive or be on dialysis. Your dialysis date actually is your waiting date. So if I come to get listed and Dr. Sagi comes to get listed and I'm preemptive and he's been on dialysis for 10 years, he walks into that room with 10 years of time and I start at 0. And time is accrued whether you're active or inactive, which is why you'll see a lot of times in the kidney list that people will go in and out of inactivity. There's no downside to it, but it prevents us from cross-matching and potentially transplanting somebody who's not ready. So if somebody has what is going to be a medium to a long-term issue, insurance, healthcare, psychological, whatever it is, we will inactivate them. There's no reason for them to show up on the list. So what drives kidney allocation? We talked about that before. I'm going to skip over that for a minute. The main driver of kidney allocation is the donor. The Kidney Donor Profile Index, it is a calculation of these different variables with different weights put on different variables. For the most part, the ones that pay a very large part is the donor age, history of diabetes, and ethnicity. So you can have an African American male who's 60 years old who has a history of diabetes, and his KDPI is going to be extremely elevated even if his diabetes is under control and his creatinine is 0.5, which is why sometimes it's really hard to use this as a measure of how good the kidney is. The same with the HCV status. HCV is significantly elevates your KDPI. But if you have a hepatitis C positive organ and a hepatitis C positive recipient, it doesn't make any sense not to use it, and it's not a high-risk organ. So on the other side, what drives how the patients come up on the list is their estimated post-transplant survival. And it's like playing golf. You want the lowest score you can get. So the lower your score, the better you are. The healthier, they're deceased donors, but the better quality kidney the donor is, and the more likely the recipient is to have a long life expectancy post-transplant. This is, in my mind at least, a more fair way to do this than we did it used to be based on age. Pediatric allocation used to go anybody who was 35 or under. The donor was 35 or under and went preferentially to the children. We have people who are under 35 who are on our list. We certainly wouldn't use that to transplant a pediatric patient. You can have a 40-year-old donor who's extremely healthy that you might put into a pediatric patient, and it would be a very good match for them. So this uses medical criteria more than age. And this is a really, really busy slide, but this is exactly how kidney allocation happens. This is the donor, these different sequences, and the donor drives the list. So, and this doesn't happen that often, unfortunately, I'm sure, well, I guess fortunately, but unfortunately for the recipients. Most patients fall here between a KDPI of 20% and 85%. You have some outliers of the exceptionally good kidneys, and then the more marginal kidneys, what used to be your ECD kidneys. So your really, really good kidneys, and you'll see all the way across the board, and this is what Dr. Norian talked about, your highly sensitized patients are given priority, and your perfect matches, 0 ABDR match, is given priority. So HLA and PRA plays a large part of allocation where it did not play quite this much beforehand. Prior living donor also given priority, except for here, because the goal is to prioritize the living donor for those kidneys that are considered standard or excellent, not for those that are considered more marginal. And then the younger patients go preferentially to the pediatrics, the healthiest adults, and you can see it goes basically local, regional, national, and the same here. And the variations are that the pediatrics are not prioritized when the patient gets to be outside of what's considered an excellent candidate for them.
Maybe to go back, Carrie, I mean, for the nursing staff that is not familiar with it, I mean, you can only imagine how complicated it is to build a software to take all these things into account. So it has become almost a very complex mathematical model. I mean, U is number 1, number 2, number 3, number 4. In part, it has become so complicated to decrease the number of lawsuits that Eligibility have filed against UNOS. Because, I mean, with all of this, you know, to really understand it, I mean, it's really the computer, I mean, who tells you now, I mean, what needs to be done. Which is good because that way it has gotten out of our hands. I mean, that doesn't mean that there are no errors possible. And I mean, actually, UNOS had a few complaints. But by and large, I mean, this has become as an objective model to distribute and allocate organs as it possibly can. And I think Carrie mentioned that. I think it is now really for kidney transplant, not just based on the waiting time, but also really on need. Because I mean, for pediatric patients, I mean, having a kidney transplant is of a different urgency than for adults.
And the nice thing about this is, as ridiculously complicated as this is, and it is, it's very simple as a coordinator, because when you get a list, what happens is that donor coordinator puts the information in, UNOS runs their list, and when we see the list, it just spits it out in order. I can't see the other patients on the other list. I could see like number 2 is our patient, Mr. Smith. You know, number 1 is somewhere else. We have number 2. Number 3 through 15 we don't have. Number 14 or is so and so. So it really keeps it simple. You just go down the list. There's no thinking involved as far as the order of sequence, but the math behind it is phenomenal. So, and pancreas allocation is actually much simpler.
Now,
Whoops, sorry.
Sorry, Carrie, interrupting again. So sometimes we get offers of what we consider very crappy kidneys, and you guys on the floor see that because these kidneys are not functioning right away. So once the list is generated, I mean, number 1, number 2, number 1, well, they're all called. But sometimes we get a call in the middle of the night, Dr. Samani, John, or I get calls, and then my first question is, what number on the wait list are we? And it could be number 2,200. So that tells you 2 things. First of all, I mean, this must be not a perfect kidney, because otherwise, I mean, you at number 2,200. Being called from California is not, I mean, what makes that a great kidney. And the second thing is that if that kidney comes your way, you do still have some leeway as what you want to do. So let's say you're number 2,200, the kidney comes to you, there are issues. I mean, we take it to the operating, we take a look at it, and we take a biopsy, and if everything comes back, we still think this is transplantable. And we do it. But let's say our candidate number 2,200 on the list is not a good candidate, and now we're down to 2,800 or whatever, our next candidate. So we would call back and say, hey, 600 patients below is someone that we can give it to. Can we have it? So most of the time, I mean, then we can have it because by then no one wants it anymore because everyone is scared to death. I mean, now they're down to 2,800. Waiting time is high. We may need a cross-match or whatever. Then we can start using it for someone, maybe the number 2,000 or for someone else. And then what we do is we usually give it to a patient who has accepted an extended criteria kidney that is low on the list. By doing so, we give someone a chance who otherwise, I mean, may have waited 6 or 8 years, but is willing to take an extended criteria kidney because that's what it is. It's not a perfect kidney. And that way we get at least, I mean, the kidney rather than discarding it. We get a transplant. So there is still a little bit of leeway in the way we can do it, if in fact it's very low on the list. But how does that happen then? I mean,
however, it happens.
Happens pretty often here.
Happens pretty often.
Right. Yeah. Right. So despite, I mean, the rigid scheme that Carrie had presented, there are still exceptions to the rule, and those are usually kidneys that don't work. Now, in the 1980s, there was someone here by the name of Georgia Buna. Georgia Buna trained with Tom Starzl, and as many of you know, Dr. Starzl was very aggressive in taking an organ. So Georgia Buna decided to take on all organs, all kidneys that were not accepted by American and Canadian centers. That was cyclosporin had just been introduced. So he takes everything. So after he takes everything, he ends up with a 1-year graft survival of all the kidneys that were denied at other places. 1-year graft survival of 78%. So that's when we suddenly realized that, I mean, there has to be a better understanding of which kidney still can be accepted, which one cannot be accepted. And it's really an art. It's more so for the liver, because if you accept their marginal donor and the liver does not work, the patient will die. With the kidney, the patient goes back on dialysis. But nevertheless, based on those early experiments, we realized that we can use some of the kidneys that are turned out. Now, you cannot, Dr. Johnson, Ron, and I cannot take on any kidney because now we have the SRTR, as Carrie mentioned. They will flag us immediately if our results are not good. have to be somewhat prudent about which organs we accept. We need biopsies and everything else, but in the end, it can actually be done successfully, because imagine you have 100 kidneys and 78 of those that were considered to be discardable are transplanted and eventually function. So I mean, it's a rare and precious resource, and we have to make the most out of it. So sometimes when you see patients, I mean, they don't make urine for days or weeks or so. That is not because, I mean, it was a poor choice, but it's because you want to give as many patients as possible an option to undergo a kidney transplant. Just as a background, because I know you guys frequently are asking, hold a second, kidney is not working, I mean, is that really, I mean, the way it should be? And frequently we see patients, not frequently, but we do see patients, I mean, where it takes weeks until suddenly, I mean, there's urine production. There are also a few percent where we don't see urine production, but in most of the patients we do. So even these marginal donors, I mean, there is a purpose, I mean, to do these transplants.
The other thing to keep in mind is that, you know, along the lines of one man's garbage is another man's gold, is that there are centers around the country that have very short waiting times. So if you think about what Dr. Tedler said about who uses the high KDPI kidneys, a lot of programs, and it's mostly concentrated in the high urban areas where you have a high population, a lot of medical care. You have a large percentage of your patients in those centers, and then you're in the middle of the country or in the south, and they have a large donor population, high consent rates, shorter waiting times, and what they might not use because they're only waiting for 18 months looks a lot nicer to us when our patients, our B patients, can wait up to 10 years. So you're looking at it through a different lens. So I do encourage you, I know, and I realize that it's very difficult when you give something a numerical score. It's 1 is good and 100 is bad. But you have to remember that these are transplantable kidneys. So even a KDPI of 100%, it probably will work for somebody. I mean, some of them won't work for anybody. But just because it came from another state or just because it has a high KDPI doesn't mean that it's a bad kidney.
Carrie is absolutely correct. Take an example, I mean, that we sometimes see from California. So first patient UCSF turned down. Next patient UCLA turned down. Then it goes to a small center, let's say in Nevada. Well, they look at it and say, hold a second, San Francisco was there to turn it down. That must be a terrible kidney. So then you have this snowball system, you know, and then suddenly you are 2,200 as a person on who's basic and then that kidney works. So Carrie is absolutely correct. The KDPI, and obviously, I mean, 5 is very good, 95 is bad. But I mean, we have all done KDPIs and kidney donor risk index of, let's say, 98% with reasonable outcome. So, and particularly on weekends in the middle of the night, I mean, sometimes good kidneys are being turned out, and then someone just has to pick up on it and say, hold a second, I mean, these 2,000 patients that were bypassed here, I mean, this is still a good kidney and we take it. So that's also a way to eventually expand the program by being more aggressive about what organs you're accepting.
And I'm just going to touch on this very quickly because I know Dr. Sagi has a very thorough presentation about pancreas and criteria and donor criteria. I just wanted to give you from the UNOS standpoint, as far as kidney pancreas, first of all, we talk about, and Dr. Guzman talked about pancreas alone, kidney after pancreas, kidney pancreas, actually islet cells, but we're not doing deceased donor islet cell transplant. It's all one, these are all one list. So even though we talk about them separately because it affects the recipients separately, when it shows up as a donor, it's a combined pancreas, kidney, pancreas list. So it's a little difficult to describe because it doesn't really work exactly the way it sounds. But basically, to be medically eligible for a kidney pancreas, so from a recipient standpoint, they have to be registered on the kidney wait list. And they have to either have diabetes or pancreatic exocrine insufficiency. It doesn't define what type of diabetes. It doesn't say type 1, type 2. It doesn't tell you anything about what their lab values have to be. They just have to be diabetic. And as far as for waiting time, it runs pretty much the same way as the kidney list. So if we have a patient who's on our kidney list for 5 years, and he gets evaluated in a transplant clinic, and he's now eligible for a KP, when he goes to the kidney pancreas list, or the pancreas kidney pancreas list, those 5 years are going to go with him. So although the waiting time is about 3 years here in New York, 1 to 3 years depending on your blood type, a lot of our patients, as they get listed, once our pancreas program is actually approved by UNOS and we could start functioning, a lot of our patients are going to go to the top of the list. So even though we're a new program, expect that we're going to be doing some transplants sooner rather than later. So we're not going to have to wait 3 years until we transplant somebody. However, if you're over 18, in order to actually show up and accrue time on the waiting list, you have to be on insulin. So you have to be on the kidney wait list, and you have to be on insulin, assuming that you're diabetic and it's not exocrine insufficiency. And then the pancreas listing criteria is very similar. You have to be diagnosed with diabetes or have pancreatic endocrine insufficiency. And I put this up because it's part of the policy, but it's not something we're going to see here. For those programs that do multivisceral, sometimes the pancreas kind of comes along because it's all in the package. So if you require pancreas as part of a large multi-organ transplant, particularly in pediatrics where they do a big cluster transplant, then you need to be on the list because you're accepting that organ, even if they get put on the list at the time that they get transplanted.
So 2 comments to that. The reason why we do it is we do a test and liver transplant. The bile duct is the accuracy. So by keeping the pancreas in place, you don't have to do a bile duct. So these transplants take 10, 12 hours, and your child is gone. And then at the end of the procedure, you have to do the bile duct connection, which is the very easiest procedure. But what that has happened, and we just wrote an editorial to the SRTR. So everyone thinks what the SRTR is doing is religion. So we wondered about pancreas transplant alone outcome with a high patient mortality. So those are type 1 diabetics who don't have any comorbidities, and suddenly we were looking at an 8% mortality within 1 year. We said, this cannot be. So what we then found out is that SRTR put these patients that had a liver, intestine, plus a pancreas into the mix as pancreas transplant alone. So no kidney was done. Now, about 50 to 60% of these patients are alive in 1 year, so 40% are not. So suddenly, you bring them into a mix of, let's say, 500 or 400 other transplants, or it's actually less than that, and your statistics are completely skewed. So organizations even as sophisticated as the SRTR and UNOS and so forth, they can make mistakes. Because, I mean, it was difficult to understand why suddenly we had a mortality higher in pancreas transplant recipients than the one that received a pancreas and a kidney. And as you can imagine, you do a 2-organ transplant, the mortality is higher than with 1 organ. And then we realized that, I mean, the reason is because, I mean, they just put that into the equation and called it a pancreas transplant alone. So again, I mean, you have to be very careful about what you are doing. And for multi-organs, the pancreas serves no real purpose other than being or allowing us to do the procedure in a less complicated way. And whether we use an entire pancreas or part of the pancreas, secondary. But it really serves no purpose because these patients are usually not diabetic to start with.
And then, like, just very briefly, as far as the allocation, and this is on the organ procurement side, there's 2 main sequences. If the donor is over age 50 and his BMI is less than 30, or if the, or if the donor is over age 50 or with a BMI greater than 30. And those secondary donors are the ones that are considered slightly less ideal for whole pancreas. And in this particular sequence, the islet cell people will get priority before some of the national pancreas programs. But like I said, it really doesn't affect us. And I know you're going to talk a little bit about about donor selection. But for the most part, we will be hopefully seeing patients from sequence number 1. And like I said, it really is just one big list. So we're going to show up with all of the programs. A lot of programs that do kidney, pancreas, and pancreas here, but the patient numbers are pretty small. They're probably, I think we did, what was it, like 18 or something last year in this donation service area, I think, or something like that. Pancreas and, yeah.
It's about, it's
So.
been between the numbers of 15 and 25.
Yeah. So I think Dr. Grusner plans to double it next year. So, and I think that's about it for me.